Hi there, everyone. Welcome. We're just gonna give it a couple of minutes here, let people join before we get started. But feel free to say hello, type in the chat, let us know where you're calling in from, your role in long-term care. Looks like Sunita, you might need to enable the chat. I can only see host and panelist if you want to check that. Oh, no, it looks like it's working. Welcome, Rebecca. Just give it one more minute and then we'll get started. Hi, Janice. Well, hello, everyone, and welcome to our Victoria South Island LTCI learning series on alcohol use disorder and long-term care. I'm Jessica, the LTCI program manager, so welcome. It is with great respect and appreciation that I am speaking to you today on a kind of overcast but still beautiful Sauk Nation day down in Sauk here. Feel very lucky and thankful to live and work and play in this beautiful area. So a couple of housekeeping items. This is a CME event. A certificate will be emailed to you in the next few days. There will be an evaluation at the end of the event, so please take a moment to complete it as your feedback is very important to us. The event today will be recorded. It won't be available on our website, but it will be available by request. So if there's a colleague who has missed it or you'd like to review it, please reach out to us and we can send you a link. If you have questions, please feel free to unmute yourself and ask away. We like these events to be interactive. So I will introduce our presenters this evening in no particular order. We have Dr. Chris Stuart. So Dr. Stuart graduated medical school in 2017 from UBC's Southern Medical Program, SMP, in Kelowna, where he became interested in underserved populations and addictions. His residency finished in 2019, focused on a combination of acute inpatient medicine and inner-city addictions medicine. Since residency, he has come back to Victoria. Dr. Stuart works at Kool-Aid as a hospitalist, has one of the physicians at Safer Victoria, and is the primary care lead for downtown Victoria. Lastly, Dr. Stuart is MRP for the Summit Specialized Populations Unit. That's a long-term care unit dedicated to individuals who are difficult to manage on a typical LTC ward due to more severe and active substance use disorder and/or mental health. Next up, we've got Dr. Alicia Pawluk. Dr. Pawluk is a family physician practicing in Victoria with special interests in care of the elderly, emergency medicine, and addictions medicine. She has a specialty training in family medicine, so care of the elderly at the University of British Columbia, and integrative medicine at the University of Arizona. Dr. Pawluk is assistant professor at the University of British Columbia and UBC Director of Community Geriatrics. Last but not least, we've got Dr. Chris Blashko. Dr. Blashko is a psychiatrist in Victoria. His practice prioritizes comprehensive patient education, ensuring individuals fully comprehend their health status. He specializes in addressing patients afflicted by acute or chronic mental health conditions. His overarching aim is to alleviate patients' distress and enhance their coping abilities. Dr. Blashko works alongside Dr. Chris Stuart at the Summit Specialized Population Unit. So without further ado, be over to our presenters for this evening. Thank you.
Okay, thanks so much, Jessica. So lovely to have everyone here. Thank you very much for joining us. Last time I rambled a little bit at the beginning, so I'm going to kick us off pretty quickly and hopefully we can move on. So to begin with, like Jessica, going to just do a quick land acknowledgement here. I'm calling in from the unceded ancestral territories of the Lekwungen and Wasanic people of what is currently called Victoria. But I would also like to acknowledge in this slide that we are representing people from all over Vancouver Island and British Columbia. So I want to honor and acknowledge all of the First Nations people of the island of BC and their contribution past, present, and future. As far as disclosures go, none of us have any. We wish. The classic statement. Okay, so we're going to be using Slido for this talk. So if you would like to go to slido.com, there will be a code that you can put in as LTCAUD, long-term care alcohol use disorder. You can also scan the QR code if you want, and Dr. Pawluk also put the Slido link in the chat. That's how we're going to get you guys engaged a little bit more than last time. Last time we had a couple of questions, but hopefully we're going to have a little bit more engagement with the group today. So if you feel comfortable, please do that. You can just do it on your cell phone, nice and easy. Also, feel free to fire off things into the chat, but there's also a chat with Slido, and that way we can upvote questions, and we can have a little bit more of a dynamic feedback. So if you wouldn't mind using Slido, that would be great. But if that's a bit of a barrier, please just throw your questions in the webinar or in the chat, or unmute and ask. So before we even begin, here's the first question. How comfortable are you in treating patients who drink alcohol? And I'm going to let Dr. Pawluk help manage some of the Slido stuff here as well, so you don't just hear from me.
Click on it. Nope. I click on it.
Sorry, my apologies. I thought we weren't going to have any hiccups, but we might just have a quick hiccup on the Slido stuff. Uno momento, please. Do I need to relog back in?
No.
Oh, no, there we go. It's working. Okay. Sorry, there is a little bit of a technical difficulty here, so we're just gonna roll with it. Okay, so overall, the majority of people are split somewhere between somewhat comfortable and somewhat uncomfortable. There's fairly few people that are very comfortable, and thankfully nobody is very uncomfortable. So that's a really good start. So most people are in that somewhat comfortable to somewhat uncomfortable range though. So that's great. Hopefully we'll be able to teach you some stuff, and yeah, let us know in the comments as we go along. So in general, we're just going to do a brief recap and background about what we talked about last time. Then we'll go into the general approach to substance use disorders, specifically alcohol this time. We have a bit of a case that we'll introduce. Then we're going to go into some specific interventions and what we can do. We're going to wrap up the case and do a bit of a summary and hopefully get to a solid at least 30 minutes of Q&A. If I'm too quick, please let me know. I am going to be a little bit quicker than last time because I rambled. Okay, so brief recap from last time. The long-term care population is shifting. We are seeing a very clear shift from our classic, sweet little old folks to a younger population overall. There's a lot that goes into that, but a combination of the baby boomers in general having more resources to mobilize, being able to afford private long-term care, being able to afford home supports, and staying at home longer. So the people in our public long-term care population is shifting. They are typically lower SES. This has been happening for decades, and it is likely going to be continuing to happen over the next couple of decades. As we talked about last time, substance use disorder in older adults puts additional stress on vulnerable body systems, and it generally reduces quality of life. And some of our major goals are improving quality of life. We want to remind people that it's never too late to reduce the impact from substances, and that moving into long-term care can precipitate or worsen pre-existing substance use disorder or create a new one due to a whole host of reasons. Gold standards is shared patient-centered decision-making. One of the things that we talked about in the discussion last time was whether or not patients, really had that ability to make some of these decisions, and we'll get into that again today. And as I mentioned about goals, our goals here really are about reducing physical illness, increasing social engagement, and improving psychological well-being. Getting back to the patient-centered component, harm reduction really is important for those who don't want to stop or only want to reduce their use. And the also difficult part of all of this is part of the comprehensive assessment always includes a capacity assessment, and hopefully we'll get into a little bit more of that later on. So again, a little bit more of a reminder, drinking isn't an issue with younger folks. The rates of daily drinking in the 65 to 70-year-old age group is 3 times higher than that of the 15 to 54 age group. People greater than 65 years of age are about 10 to 11% of the population engages in binge drinking in any given month. And so this is an issue in older folks. This is a quick chart that just outlines the rates of drinking, both by age group and by sex. And what we can see is whether we're talking about active drinking or binge drinking, anywhere from 5 to 30% of individuals binge drink on any given month. So that ties in with the about 10% on average. And up to 65% of people drink regularly, or men at least drink regularly at any given time. There is a predisposition towards men compared to women, but it is a problem in both genders. Not going to spend much time on this, but older folks do end up hospitalized with alcohol issues. This is just a good bar graph showing that older folks have rates of hospitalizations fairly equivalent to younger folks. There is a peak in around the mid 50s to 60s, but it is definitely an issue in older folks as well. And there was a really great webinar put on by the UBC CPD, Continuing Professional Development, on the 9th, so just 2 days ago. And it was held by a panel of local experts across BC. And one of the things that they pointed out is that there are more hospitalizations for alcohol than for heart attacks. So alcohol and alcohol-related diseases result in more hospitalizations than cardiac disease. So it's a very important picture. And it's certainly the most prolific substance that's consumed in North America, at least. One of the other things that we mentioned last time is this concept of physiologic versus chronologic age. I touched on it briefly last time, but I do want to point out that aging has many dimensions, and biological is one of them, but psychological, social, and cognitive risk factors are all encompassing in there. In a lot of the guidelines, older adult, it refers to those of 65 years of age and older, but several of the guidelines pointed out that several issues here might be relevant for individuals that are younger than 65 due to medical, psychological, and social contexts. And also conversely, many people over the age of 65 might be better suited for approaches to younger adults in general, and to really think of an individual's age, not in just their chronological number of years, but as a more encompassing concept of how they're doing and what their overall physiologic and organ age is. This isn't something that we talked about last time, but it is something I do want to just throw in here at the beginning while we do some early groundwork. There are a lot of hidden symptoms in substance use disorder when we talk about the elderly, whether that's physiologic or biologic age. Specifically with alcohol, there are some hidden symptoms such as just changes in sleep pattern, or maybe some cognitive concerns, but then things like muscle wasting and malnutrition, mood disorders, people that are unusually restless and agitated, even chronic pain in and of itself can be a red flag for alcohol use disorder. Things like incontinence, self-neglect, and multiple injuries are also good red flags for us. And so these are just some things to think about. These are symptoms that pop up day in, day out in long-term care, but they could be red flag signs that there's an underlying substance use disorder. And say chronic pain as an example, that could either be due to unexplained chronic pain and somatic complaints, myalgias, abdominal pain, chest pain from their alcohol intake, or it could be people treating their known chronic pain disorders like spinal stenosis, OA, that kind of stuff, with alcohol as a painkiller. So we're going to loop back in on a lot of these symptoms as we go through the talk, but I just want to lay out the concept of hidden symptoms. So before we go too far here, I want to just get a bit of a temperature check. At the end of the last presentation, there was a little bit of controversy, we'll say, around some concepts of harm reduction, the patient-centered approach, allowing patients to consume alcohol in long-term care, that kind of stuff. And I would just love to get a bit of an idea about how people are feeling and what comes to mind when you think about harm reduction. So we have a Slido here, and it's what's called a word cloud. And it would be great if you guys could participate and just let us know what comes to mind when you think about harm reduction. And it looks like it's working over here. So I'm going to get Dr. Pawluk to talk from here on out on this.
I'll just give you guys a few seconds to get the results. I can see there's still like lots of people typing, so it's going to be a minute, but we kind of wanted to use the slide to touch on a little bit about, oh yeah, okay, great, so many things going on now. Basically that it's challenging, it's really complicated, and it can be useful, it can be a, a safer strategy, a compassionate strategy. So there's lots of conflicting emotions, and as either addiction specialist or as people who do older adults or people in long-term care, something that we'll run into pretty frequently. So I'll leave this poll up so you guys can watch the results, but I will go to the next one.
Okay, thank you very much for that. So it looks like there amongst this group is a bit of a mixed bag of feelings and emotions when it comes to harm reduction. That's great. Hopefully we can work through some of those things. I saw some things like compassion, autonomy, safer options come to the forefront, but then also slippery slope, contentious, controversial, that kind of stuff. So I hear you. It is it's complicated, and there's a lot of emotion around it. So part of what we want to do is update you guys on some of the recent literature here. There's been quite a lot of change around Canada's alcohol and health guidelines here. So there's a 2023 publication entitled Canada's Guidance on Alcohol and Health. And it changed the dynamic of what we consider safe drinking. So next Slido for you guys, and again, I'll get Alicia to work on this one with you, but it's what is the weekly threshold for low risk consumption based on these new guidelines? Oh, you're
Right.
okay. Sorry, we jumped ahead on the next one, which is screening. But hey, we can talk about this first, and then we can go back to the guidelines for alcohol use disorder. Yes, screening. So the question is, how often are you supposed to screen? And if we get out of this and I share my screen again. Screen. There we go. Okay. So if we talk about screening, the answer is monthly. So, sorry, annually. So all patients, including older adults, should be screened for alcohol at least annually and at transitions of care. And it should be done more frequently if people have certain risk factors or life events. So if you're drinking more than your low risk guidelines on screening exam, if you have a history of alcohol use disorder, a family history of it, some of those signs and symptoms that we talked about earlier in the hidden signs and symptoms, especially depression and anxiety, if caregivers express concerns, major life changes, such as going into long-term care. And this is directly out of the Canadian guidelines on alcohol use disorder in the elderly. And that's a moderate evidence, strong strength recommendation there. So it's important to screen annually and at transitions in care. And the other thing around that is older adults should be asked about alcohol use in all care settings, including hospitals, but also long-term care facilities. And that was a high quality evidence and strong recommendation from the guidelines as well. But we're going to pop back up here and go to this earlier Slido about the weekly threshold for low risk alcohol consumption.
Yeah. So you guys have done your homework. I'm really impressed. The low risk alcohol guidelines are relatively new. And certainly when I trained in the UK, 10 to 14, depending on your sex was kind of what they were recommending. But certainly, yes, it's now less than 2. Anything greater than 2 standard drinks a week is considered no longer low risk. So after 2 drinks a week, you start to see health and other effects from. I often get patients telling me that this is unrealistic, but this is also a good place to start framing the conversation.
Perfect, thank you. So yeah, moving on to the next slide here. This was a significant departure from previous guidelines that, like Dr. Pawluk was saying, it recommended anywhere from 10 to 14 drinks, depending on whether or not you were male or female. And now instead of having a dichotomous black and white, good versus bad, high risk versus low risk, what these new guidelines are trying to do is understand that there is a continuum of risk. I think most people understand that whether you're talking about eating donuts or drinking beer, there isn't a clear cutoff between this is good for you and this is bad for you, but the more donuts you eat, the less good for you it is. Same thing with alcohol. So what they've really realized is drinking no alcohol at all, there is no risk of alcohol-related issues. And the more you drink, the higher the chances of having alcohol-related healthcare complications there is. At 1 to 2 drinks per week, there is very little to no evidence that individuals will have long-term alcohol-related consequences for themselves or others. As you increase beyond that, there is an increasing continuum of risk, whether it be cancer, cognitive impairment, cardiomyopathy, liver disease is the obvious one that we all know about, but falls, everything. There is a continuum of risk that is directly correlated to the number of alcoholic drinks that you have per week. So really what we're not trying to say is you shouldn't drink you shouldn't drink more than 2 drinks per week. It's understanding that there is a risk associated with that. And does that risk correlate with your personal level of risk? Another thing that we do need to remember is that standard drinks are standardized. 5%, 355 milliliter or 12-ounce can of beer, a 12% alcohol by volume 5-ounce or 150 ml bottle of wine, or a 1.5 ounce or 45 ml shot of 40% spirit. And patients always love to bamboozle us by saying that they only drink 2 or 3 beers, but those are 9% tall cans, and we are all much too wise to fall for that, but just want to point it out. Okay, so that's a lot of the new evidence around weekly consumption. We talked about screening. Older adults need to be screened, and like Dr. Pawluk and I and Dr. Blashko pointed out last time, if we were to recommend a single screening tool for alcohol use disorder in the older population, it would be the Short Michigan Alcoholism Screening Test geriatric version, the SMAST-G. And that's not just something that we're just pulling out of nowhere. There's a reason why we recommend that. These are the validated scoring tools or screening tools, sorry, for alcohol use disorder. The first two are things that we've probably heard of, the audit or the CAGE tool. Those are not validated in the elderly. They require intact memory and mental calculation. They're often, like specifically for CAGE, they are actually known to be ineffective for older adults. And then when you go into the bottom three there, the SMAST-G, CARIOT, and SAMI, we're recommending the SMAST-G. It is only validated for alcohol, but and some questions do require some insight, but the CARIOT tool there, you require like permission from the author, and the SAMI tool is quite challenging to score. So there is a reason why we're recommending the SMAST-G. It really is the best. Oh, oops, let me just pop that guy over there. All right, so you might recognize this slide from our past presentation. This is our general approach. So really, we don't need to go into this, but we talked about this last time. Every good approach starts with screening and comprehensive assessment, though, and eventually ends with shared decision-making, a substance-specific treatment, and plus or minus a referral if you really need to. Hopefully at the end of this, you'll feel comfortable and you won't need to do the referral. And when we say comprehensive assessment, again, you'll recognize this from our last talk. So one thing I want to point out is we always need to get a full substance use history. So I guess I'll take a step back and say, we always start with a screen. If the screen is negative, take that as you will. There's always false negatives, and you and your clinical decision-making are best to understand that. But if the screen is positive, then you need to get a proper full history of substance use, medication use, comorbidities, functioning, cognitive screening, determine whether or not they have capacity. So, segueing into the case here, we have Mr. Ethan O. Henderson, and I am a nerd, and so I had to make this ETOH. I am sorry. I'm actually not sorry. It's great. So, Mr. ETOH is a 78-year-old gentleman. He lives independently. He ends up not being seen by his neighbor for a few days, and his neighbor asks the police to do a wellness check on him, and he's found to be disheveled. His home is unclean. There's a couple of alcohol bottles scattered around. There's a burnt pot, multiple cigarette burns in the carpet, and they just didn't feel like he was safe, and so they brought him under a Section 28 to hospital, and he was admitted with a diagnosis of failure to thrive and self-neglect. When he's in hospital, he was noted to be quite weak, hyponatremic, malnourished, fairly cachectic. He had a bit of an AKI. He was pleasantly confused, but he wasn't delirious. But a couple of days into his admission, we'll say that he develops a delirium, and, doing a proper good delirium workup, his hospitalist doctor notes that he has some E. coli in his urine and figures, it's probably a UTI. 3 days of macrobid, there we go. But that doesn't really settle it down, actually, and he ends up having quite a protracted delirium lasting at least a week. He gets multiple doses of Seroquel, loxapine to help deal with his agitated delirium. Eventually, he settles out, but after a little bit longer than one would expect. And eventually, it's felt that he's actually unsafe to live independently due to his cognitive deficits, and he ends up getting waitlisted in hospital for long-term care, like that ever happens. In this scenario, he gets placed a couple of months after being in acute care. And this is the quick and dirty version of a combination of a couple of cases, but these are real cases. And we're going to pick him up a little bit later on, but that's basically all that happened in his admission. So when you read that, it doesn't seem all that comprehensive. But yeah, we'd love to hear from you in another word cloud. What do you think was missed in that workup and admission?
There's a lot of really good points coming on here. Substance use screening is a big one, of course. These are somewhat leading questions. They wouldn't, UBC would not accept these as valid exam questions, but certainly taking you for a substance use screening, really just to point out that this is something that's very, very frequently missed. I work in the emergency room, and I can tell you that even I'm guilty of not doing this properly, even though I have. So very challenging, but really the social history, which would include a substance use screen, is very important. And also not assuming that just because of someone's age, they're not using their substances as well as alcohol.
Perfect. Yeah. So thank you guys for picking up on all that. In that scenario, somebody did screen him for substance use disorder. I was a bit cheeky leaving it out, but the question was, do you drink? And he said, no, not much. And that's where the conversation ended. I also saw somebody there in the chat just mentioned social history and health history. Rosalind there, thank you very much for that. So yeah, I agree. He was not appropriately screened for substance use disorder at all, despite the fact that there were numerous bottles left around that the paramedics noted. So yeah, having the chat, screening people. So it's always important to ask our patients for permission to begin with, and a lot of these are directly from there is a guideline on alcohol use disorder in the elderly. That's a Canadian publication, and I'll show you the specific recommendations there. But especially when talking with older folks, it's quite important to provide context and ask for permission to discuss their alcohol intake. Sometimes, depending, and again, your clinical gestalt will tell you, sometimes it's actually worth holding off and establishing some rapport with the patient before asking. And also, it's important to ask if you can discuss the alcohol use and its impacts with friends, family, and care teams so we can get everybody involved there. So you don't necessarily need to dive in off the deep end. So gathering data here. So screen with the SMAS-G. Do a quick screen, and if at all possible, if it's positive, then you go on and get your collateral history, family, past medical, etc. That's when you do your cognitive screen and capacity assessment to your functional assessment, and eventually we can figure out what to do to treat it. And some of the some things that we can do for a treatment for alcohol use disorder is a brief intervention. There's anti-craving medications, there are psychosocial programs, there are withdrawal protocols, and then there's IMAP, or Individualized Managed Alcohol Program. So we're going to go through the pros and cons and when to use each of those. And this little box down at the bottom, do you mind if I ask some questions about how much you drink, is again directly from the guidelines.
Just to quickly jump in as well, I had a really good question in the Q&A about who can administer this SMAS-G.
So it can be administered by anyone. It actually can be self-administered by a patient, although it's maybe, it depends how reliable they are, what their reading level is, that sort of thing. So there's no restrictions on it. Island Health might have their own restrictions, but in terms of the actual substance, it's been out since the early 90s at least, and it's very reliable. There's no kind of necessarily training that you need to do it.
Great, thank you. So with respect to some of the treatment options we have, again, straight from the guidelines, all patients who screen positive for alcohol use disorder should be offered a brief intervention. And there's quite good literature on this. A single 5-minute brief intervention session is likely to reduce alcohol consumption. And there's a good Cochrane review quite recently about this, showing sustained reduction of alcohol use and alcohol consumption 1 year later. So there is significant evidence supporting brief intervention in older individuals, specifically in mild alcohol use disorder. And when we think about, well, what is brief intervention? It's basically motivational interviewing. We've all done this. We've all done this over and over again. We discuss a patient's health concerns, you collaboratively set goals, you develop a tailored plan to address the goals with patient preferences, and you use probably one of 2 motivational interviewing approaches. We're not going to get into motivational interviewing here, but the FRAMES approach or the 5 A's approach. I was taught the 5 A's approach. However you do your motivational interviewing, basically brief intervention is just saying, let the patient know that there are health concerns about drinking, you set goals, and then use a motivational interviewing tool to develop the plan to get to those goals. Bread and butter of what we're going to be talking about here are anti-craving medications. So there are 2 gold standard anti-craving medications that we use quite frequently, naltrexone and acamprosate. Then we are into the GABA / anticonvulsant medications of gabapentin and topiramate, and then good old-fashioned antabuse or disulfiram. So from our gold standard medications, naltrexone is probably the number 1. It's a once daily dosing medication. The issue is that it is an opioid antagonist, so it blocks opioid receptors. If people are on chronic opioids, it will cause precipitated withdrawal, and it will reduce the efficacy of short-acting opioids like breakthrough hydromorphone. It's also not recommended in acute hepatitis or hepatic failure. There's a couple of stars here around the decompensated cirrhosis. Dr. Paxton Bach was one of the speakers just 2 days ago on the 9th on that alcohol use disorder webinar that I was talking about. He really feels like the potential liver toxicity from naltrexone is probably lower than the liver toxicity of ongoing alcohol consumption. That being said, if somebody actually has symptoms like hepatic encephalopathy, ascites, like actual clinical consequences of their decompensated cirrhosis, then probably choose acamprosate or really whatever the best anti-craving medication for that person is, maybe just at a lower dose. You should probably call a friend at that point, but just keep in mind that naltrexone is really our go-to if we can use it. Acamprosate is also great. Unlike naltrexone, it's contraindicated in renal failure. And the main issue with it is TID dosing. None of us are great with TID medications. That being said, in a care setting like long-term care, where you can guarantee TID dosing, it's actually not that bad. Just keep a close eye out for your folks with a creatinine clearance of less than 30. Our gabapentin and topiramate options, these are becoming more popular in younger folks, but there is limited efficacy compared to the above 2 options in older individuals, and they can cause cognitive impairment, sedation, drug interactions, and there is a potential for misuse there, so do be careful with those. And then disulfiram, generally discouraged. It's used as a stick as opposed to a carrot. My practice at Kool-Aid, I had a handful of older folks who really, really, really liked disulfiram. They didn't want any of the new stuff. They really felt like antabuse was the best thing for them. So again, the best medication is the medication that is best for your patient. When I say psychosocial programming, I really mean something along the lines of a 12-step program, CBT, and your relationship. And again, this is straight out of the guidelines. 12-step programs are often quite good for older folks. They're group-based. They help with isolation, loneliness, being held accountable. It's one of the most evidence-based interventions there is. Everyone feels like there's a big religious component to it. There are theistic components to it, but you can have atheistic as well approaches to a 12-step program. I've heard God or God being referred to as group of drunks, basically saying every other alcoholic who's gone through this program and has been successful before you. It's really important to just say, your choices have led you to this point in your life, and so you need to not be in control of your choices around your substance at this point. You need to give over yourself. You need to admit that you're wrong around your choices with substance use, and you need to give yourself over to a higher power, however you see that power. That's really the tenet of the 12-step program. That's for some people, not for everybody. CBT is useful for literally everything. So yeah, it's useful for here too. It can be done by anybody in the care team, not just by physicians or psychiatrists. And it can be accessed online. So it's quite good for that. But again, straight out of the guidelines, your relationship, a quality relationship with your primary care provider is highly protective and is an important determinant in success. Brief periodic counseling, that brief intervention that I talked about earlier with some motivational interviewing, it is an effective tool for substance use disorder, mostly around the more mild end of the spectrum. But you can also give your patients positive feedback on progress, known triggers, drinking partners, redirect to healthier activities like walking and that kind of stuff. So again, don't underestimate the power of your relationship. And that's not just the physicians and nurse practitioners in the group. Anybody who is part of the care team, your relationship is really, really, really important. This is a multidisciplinary approach, and you can really encourage your patients along. Next step down the ladder is withdrawal management. And there's a bunch of different ways of figuring out withdrawal management. So a lot of us have heard of CIWA. I want to say it's the clinical something withdrawal scale, clinical index withdrawal assessment. I can't remember what it's called. Clinical Institute Withdrawal Assessment. There we go. It's a scoring system used to measure withdrawal, often used with lorazepam or diazepam. Most of us have heard of that. You can also just get patients to taper their own alcohol, and that can be either formal or informal. And then there's IMAP, or Individualized Managed Alcohol Program. And this is a prescription for alcohol intake. And that can be used either long-term for people who don't want to cut down, or as part of a taper. And you can use that with CIWA. And I'll show you how here in a bit. Before we do that, though, we want to get a bit of a better idea. How comfortable are you with managing alcohol withdrawal?
Muffled.
Okay, so because Alicia is very muffled, I'm just seeing that in the chat. I'm gonna talk, so my apologies. One of the bits of feedback we had last time is I'm talking too much. So we'll fix that in the future, but sorry. Okay, so only 12 people have piped up so far. So far, the majority of people feel very comfortable, which is great. So that's wonderful. We next up have somewhat uncomfortable. A few people are somewhat comfortable, and only a couple of very uncomfortable. Okay, well, I'm surprised and heartened, and I'm happy to hear that the majority of folks here are very comfortable in managing that. Then there's a bit of a split, 26% and 26% between somewhat comfortable and uncomfortable. So hopefully we can get everyone on the same page here. Thanks for participating, by the way. It actually makes life much easier for us, and hopefully better for you too. So just again, so we're on the same page. Symptoms of alcohol withdrawal. I'm not going to go through this, but it is in the DSM-5. There are a bunch of symptoms here, and I will leave you to that reading. I'm not going to read everything verbatim there. But when we talk about withdrawal, there are some things that are more concerning than others. So past seizures and delirium tremens are the two biggest concerns that we have with alcohol withdrawal. Alcohol withdrawal is one of the few withdrawal diagnoses that can kill you. Opioid withdrawal sucks, but unlikely to kill you. Alcohol withdrawal can kill you. So it's really important to have a good understanding of somebody's withdrawal risk. There is a formalized tool, this PAWSS, the PAWS tool, that allows us to assess the risk of somebody's complication in their withdrawal. And really, again, straight out the guidelines, it's important to use clinical parameters, whether that is that history or that pause tool that includes those things, to determine somebody's withdrawal risk so we can make an appropriate plan. And again, moderate quality evidence, strong recommendation there. The biggest single risk factor for complicated withdrawals is a past history of prior complicated withdrawals, specifically seizures or delirium tremens. And again, straight snipping out of the guidelines here. I'm not going to read it all, but again, first bullet point, previous episodes of significant withdrawal, including seizures, delirium tremens, yada, yada. These are your high risk withdrawal features. So yeah, you guys will all have access to these slides later, so I'm not going to read everything here. Getting into the pause tool here, again, I'm not going to go through this, but the important take-home message from the pause tool is it is a highly validated, including in the elderly tool, that allows you to measure somebody's risk of having complicated withdrawal. And the take-home message is if you score less than 4, it is quite sensitive to be safe to manage that patient as an outpatient. If they score 4 or more, again, it is quite sensitive that they will likely need a higher level of care to be managed. So when you're trying to figure out if your patient is safe to manage in the community, you can whip out this tool, do a quick score, and give yourself some comfort there. And when we're actually doing withdrawal management, we use CWA. So again, straight out the guidelines, regardless of service location, benzodiazepines are the preferred pharmacotherapy to manage symptoms of withdrawal for all age groups. Now, okay, disclaimer. If a patient is at acute risk for complex withdrawal, like we just talked about with the pause, they should be managed at a higher level of care. But even in long-term care or outpatient settings, we can use benzodiazepines. Short-acting benzos tend to be preferred in older individuals, especially in things like hepatic impairment. And that being said, it is, short-acting benzos are preferred in older individuals, but for hepatic impairment, next point down, pay close attention. So the half-life of lorazepam specifically is quite prolonged in liver disease. So it does make it a little bit difficult there, but still lorazepam tends to be the preferred agent of choice in older folks because of its shorter half-life. In everybody that we're withdrawing, we should be giving them thiamine to prevent Wernicke's encephalopathy during their withdrawal. There's a ton of different guidelines around this, anywhere from 200 milligrams PO daily all the way up to 500 IV TID. Really, it's pick your poison. I err on the side of giving quite a lot. It's a water-soluble vitamin, minimal harm. I personally do 500 TID for more like the 5 to 7 days. I've, as a hospitalist, seen people's cognition clear from Wernicke's with high-dose thiamine multiple times. And a last bullet point, we can talk about this a little bit later, but you can actually use CWA to guide a formal taper off of alcohol if you feel like benzos are not appropriate, or if you don't feel comfortable prescribing benzos in this person who's also taking alcohol and who also might be taking opioids, etc. So straight out of the guidelines here, talking about harm reduction. Where appropriate, you can use CWA to taper alcohol in a couple of different ways. There's aggressive tapering, moderate tapering, and mild tapering. And the whole point here is to try and keep the CWA score less than 10. And then you can taper the medications by 1 standard drink every 3 days, every week, or every 2 to 3 weeks, depending on, number one, how frail they are, their past withdrawal history, your comfort, your engagement with the patient. So you absolutely can use this, and it can actually be quite useful with a IMAP program where you have somebody who's getting standardized dosing, you know exactly how much they're getting, and you can taper with this protocol. Okay. I've been talking a lot. A quick pause for questions, Slido. This is just an open Q&A session that you guys can pop into. Do you have any questions specifically so far?
There's one that I see here. Is my sound better? Someone could just pop in the chat if that is working a bit better. That would be awesome. But essentially, yes, there's a really good question. If someone wants to stop drinking cold turkey or completely, oh, good, thank you. And you're doing assessment. So the pause scale is basically the most helpful thing here. But not necessarily, you can be kind of misled by how little people are drinking. But if you're thinking of someone who's very old, very frail, maybe has hepatic and renal impairment, it can be like quite a small amount, a couple drinks a day, and they can have withdrawal symptoms. So it's good to kind of judge what their alcoholic, are they intoxicated off alcohol, and using the other kind of scale. So like, have they been to treatment before? Have they ever withdrawn before? And then so I hope that helps. If I didn't answer it, just pop it in the questions. So yeah, so it does factor in some ways. In theory, the more that they're drinking, the higher risk, but also their pause scale is actually more validated in general. How long should they be on thiamine? So you would want to give them the protective dose for that 3 to 5 days. I agree with Chris that I do longer. If someone continues to drink, they should continue to be on thiamine. If they're no longer drinking and you are sure that they are no longer drinking, they don't need to be on it long term. But as Chris said, there's kind of little harm to it in general. That being said, being mindful of polypharmacy, if they're no longer drinking, they can come off of it once or in long-term care if they've completed the whole course in hospital. And then how long should they be on naltrexone once they are in long-term care and not drinking? Again, like very similar. Yeah, really good question. If they are stopped drinking, basically it's kind of similar to things, and maybe Dr. Blashko will disagree with me on this one, but a little bit like antidepressants. If someone's feeling better, like when do you stop them? You don't necessarily stop them because they're feeling better. So generally, if someone was on naltrexone and I wasn't worried, like their liver function was good, and we weren't worried about, like, we don't have to put them on opioids for any reason, there's no contraindications, I would err on keeping them longer rather than shorter. And that can be like months to years sort of thing. But then again, also being mindful of other potential interactions and side effects. I don't know, Chris, do you have any input on that one?
Well, in terms of if patients still want to, the question I was reading is that they want to continue to drink and enjoy it. I think to answer that question is there harm? And then we continue to work with people and don't give up on them and maybe revisit the question multiple times. But there are individuals who in long-term care, they lose capacity and they continue to drink, and then we may need to actually intervene. So it does complicate things. So monitoring, reevaluating patients in LTC as to the harm of their drinking, and then maybe looking at something like an IMAP program with them. It's been quite successful at the summit at the SPU for some of our patients who are chronic severe drinkers. And they're on IMAP and they're doing better cognitively because they're not drinking extremely. Instead they're getting their 12 to 14 alcoholic beverages per day as opposed to 20 to 40. So I think we want to continue working with patients and reevaluating and revisiting the topic. If there's harm, try and intervene. And if they lose capacity, then we have to look at actually controlling it. So it's a little, I don't know if that answers things. Chris, what are your thoughts?
Yeah, I tend to agree with both of you. For the naltrexone question specifically, usually I say people should be, whether it's OAT for opioid use disorder and naltrexone for alcohol, you should be stable for a good period of time before discontinuing it. Again, like Chris Blashko said, complicated with cognitive issues and that kind of stuff. And I do also want to acknowledge there's 2 other questions that popped in to the chat that I can really quickly answer before I move on. So one of them was 58-year-old male with advanced MS admitted long-term care wants to continue daily beer habit of 6 drinks a day, well-nourished, supplement thiamine. Yes, that's something that is at the very end of the presentation in the recommendations that I'll throw up there. But yes, every person who is continuing to drink alcohol should have thiamine supplementation. The guidelines say 50 milligrams. The tablets come in 100 milligram tablets, just 100 milligrams daily while people are drinking, even if they're well nourished. Reasonable evidence to support that. And then there's one other question there. If an elderly person refuses to cut down or quit drinking, they have mild cognitive impairment, but able to make their own decisions. How would you help family and patient with the issue? Again, starting with the brief intervention, motivational interviewing, understanding the risks associated with alcohol consumption, understanding that it can make cognition worse, that can, everyone understands that it makes liver worse, but people don't know that it makes, your brain worse, shrinks your brain, causes nerve damage, causes heart failure. They don't understand all of the other things. And so letting people know that there are all of these risks associated with alcohol intake. That being said, if they want to continue to drink because it's important to them, they have drank all their life, then having that conversation saying, well, kind of what Dr. Blashko was saying, how about we use IMAP and we set, X number of drinks, and instead of drinking, a 26er a day, maybe you're drinking 14 drinks a day. So you get your alcohol intake, but we're mitigating the risk. That's all about that, finding the balance of autonomy of your patient, hearing what is important for them. They're in long-term care. This is the last stage of their life, so you want to make it good for them, but trying to mitigate risk as best you can. Okay, if everyone's okay, I'm going to get a move on here. So we're gonna say that we're looping. So now we've done a lot of the different interventions. We're going to loop back to our case. So we have our friend, Mr. O'Henderson, and he had a fairly poor workup in hospital, but he moves into, actually, before I go too far in this, I did want to say one of the points of his initial presentation to hospital was a couple of days in, he got delirium and was put down to UTI. They probably missed the fact that he was drinking, and he probably had delirium from alcohol withdrawal. So that was one of the key points that I wanted to make on the first one. Sorry, I didn't get there. So Mr. Henderson's been in hospital for a while, and he actually has been there for 2 months in acute care waiting to be placed, and he moves into Summit. Yay. So his primary care provider, one of you folks who attended the session, does the following. They ask for permission to discuss his alcohol consumption, and then they gather data. They screen him first, and then if positive, they move on. His SMAS-G score is 5, greater than 2 is a positive screen, so they dig in a little bit more. And as it turns out, well, once his delirium cleared, he got friends to bring him whiskey in hospital, and he was actually drinking a Mickey every couple of days and hiding it in his sheets, and his nurses didn't know about it. So in terms of standard drinks per day, a Mickey is a 12-ounce bottle of 40% spirit every 2 days, 6 ounces a daily, or 4 standard drinks a day. So just like we talked about with some of the questions there, his doc has a bit of a chat with him, does some brief intervention and motivational interviewing, letting him know that the hypertension that he developed and was put on medications for in hospital might be due to his alcohol intake. So you might be able to reduce your pill burden, might be able to help with memory and your mobility if you cut down, all of those things. And the patient actually says, yeah, sure, I'll agree to a trial of naltrexone with a goal to cut down, but he doesn't want to stop drinking altogether. That's important to him. So you make a plan with the patient to start naltrexone and start IMAP here. So naltrexone can be started at either 25 or 50 milligrams a day. In older individuals, it's generally recommended that we start at 25 milligrams a day to reduce GI side effects and that kind of stuff, and titrate up to about 100 milligrams a day thereafter as a target dose. So that is an anti-craving medication to hopefully help reduce his alcohol consumption. But we also start him on IMAP because he's told us he wants to continue drinking. So he was previously drinking 6 ounces or 180 milliliters of spirit a day. IMAP comes in 50 milliliter doses, and that's because those are airplane bottles, and that's what Island Health has decided to use here. So the way we might do it is something along the lines of saying, well, here's 50 milliliters, which is just over 1 serving. If you remember, a serving is 45 milliliters or 1.5 ounces. So this is kind of a strange way of doing it, but 50 milliliters 3 times a day. There's 150 milliliters of spirit that you're prescribed daily. A little bit shy of the 180 he told us he's taking, but then he has some TID PRN doses as well. And because he's going to continue drinking while in long-term care, again, talked about this before, but as a harm reduction strategy for chronic heavy drinkers, recommended at least 50 milligrams of thiamine supplementation, straight out of the guidelines. And practically speaking, this is 100 milligrams at least, because that's what our tablets come in. So this is what we agreed to do with him, and he thinks this is a pretty skookum plan. And initially it goes well for the first couple of days. He's asking for 2 PRN doses on top of his regular 3 scheduled doses. And, when you talked about that, well, maybe I went through that, Mickey, a little faster than every other day. But unfortunately, he's also buying some of his own alcohol now at the shop down the street. And there's been some issues with this. He's become belligerent with both staff and their residents, had a couple of verbal altercations. And one evening he was found to be sitting in his room smoking, and there was burns on the bedding. That's obviously fairly concerning and basically straight out of one of the cases right now. So in that scenario, what would you guys do? What would be your approach to dealing with that patient now?
There are no wrong answers for this question. Well, there might be wrong answer, but all the ones you guys have given are really excellent answers. Calling a friend, prescribing something to him, modifying IMAP and negotiating or doing a brief intervention. Yeah, absolutely. Collaboration engaged. Lots of good thoughts here. So we will continue.
Okie dokie. I also realize I'm running a little bit behind, so my apologies if I fly through some of this stuff. So you have a conference with the patient, CNL, his doc, his son was also there. And, he's a little bit frustrated. He felt like he should be able to drink and smoke wherever he wants. It's his home after all. He did agree that falling asleep with a smoke, though, could pose a fire risk. And in the end, he actually didn't want to increase the IMAP anymore. He just said he wouldn't consume alcohol outside of the program and that he wouldn't smoke in his room. And he felt comfortable with that. And that lasted for about 8 hours. Unfortunately, he was found to be smoking in his room again that evening, and found later that evening to have a little snooze with a cigarette sitting in his lap in the bed, posing a significant fire risk. So instead of saying, what are we going to do now? Because questions are going to take a little bit of time here. I'll wrap up and say, in this scenario, yeah, I would agree with what a lot of you said. Renegotiate, are we underdosing you with IMAP? Do we need to increase the dose of it? The tricky scenario here is when cognitive impairment becomes a burden. Sometimes people don't remember or don't agree that they've been consuming alcohol outside of the program. And even though I'm a harm reduction champion and I'm a patient autonomy champion, at some point it becomes unsafe for people to consume alcohol and be on IMAP. And unfortunately, if people are continuing to consume alcohol even on that program, sometimes you do need to discontinue the managed alcohol program. I see Chris Blashko has a comment though.
Yeah, it's just to extend what you're saying there, that one of the areas of capacity can be financial. And if somebody's utilizing their finances to purchase alcohol that ultimately harms them, that can be enough to basically say that they're not financially competent, and then their POA may be more in charge of their access to money, which has been utilized as an approach. So we don't necessarily have to declare the patient globally incompetent, but we could legally and appropriately take charge of some aspect of their choices through managing finances. And then if they're doing well, they can return to taking care of their finances. So just wanted to highlight that, particularly in the long-term care setting where we have good social work support, and usually there are secondary decision makers available. It could be a tool if the drinking and substance use is quite harmful to a patient.
Thank you very much for that. And I totally agree. Because there's only about 5 slides left, I'm actually going to skip the questions for now and just go straight to the last couple of points, and then we'll get to questions at the very end. So one last thing, and again, I'll probably get Dr. Blashko to chime in on this a little bit, but there's some fairly recent literature describing harms associated with SSRIs in alcohol use disorder. And these are a couple of snippets here. So the first screenshot there is from a guideline indicating that SSRIs can have a negative impact on alcohol consumption. And the concern is not that it makes the SSRI less effective for the indication it was prescribed for, anxiety or depression, but in some individuals, it increases their rates of alcohol consumption. So that's the concern. The second quote box down there was, again, just from the other day, just from the 9th, and it was from that panel of experts, including from Dr. Paxton Back, who's the co-chair of BC Centre for Substance Use. And they did understand this, and they said, look, we get that the evidence is out there, but it's actually lacking a little bit, and they really do need more research in this is the main thing. Oh no, sorry, that's the next slide. Sorry, this one is just saying to consider doing a taper off of alcohol and see if the symptoms of depression or anxiety are still present after the patient is not consuming alcohol anymore. My apologies. But the local experts had this to say that they understand that the evidence is out there, but they just found the outcomes inconsistent, and randomized controlled trials had limited limitations that prevented definitive conclusions. In the literature out there, it seems like specifically fluoxetine and sertraline tend to have the highest associated harms. Mirtazapine seems to be the best overall. And it doesn't address severe psychiatric conditions, individuals that are demonstrating significant benefits from SSRIs, and all those scenarios where we wouldn't advocate deprescribing. But again, this is outside of my wheelhouse. And Chris Blashko, I'll let you just chime in for a minute there.
Sure, thanks, Chris. So this is a very interesting topic for a guy like myself who prescribes a lot of medications, and I also de-prescribe from patients. So when I reviewed the literature on it, I looked back several years, even into the 90s, and this was starting to be a controversy at this time because the SSRIs came out during that time, and the prescription rates of antidepressants had increased quite substantially and are very high at this point. Like 10% of the US population are on an SSRI, for example. And these guidelines are important because they highlight a unique harm around the SSRIs. But there are many different antidepressants, as we all know. And so one of the comments I'll say is, what's the indication for using the SSRI? Antidepressants is a wrong term for these medications. It's a mechanism of action, and they're one of many different types of antidepressants. But if we have somebody who has severe obsessive compulsive disorder, SSRIs are the cornerstone. If they have mild unhappiness, I would agree, discontinuing alcohol, if they're capable of that, as opposed to prescribing, is the way to go. Education, CBT support, pet therapy, music, all these psychosocial interventions are probably more helpful than the medicines. In severe major depressive disorder, if the patient is discontinuing alcohol, you wait for a couple of weeks, and if they are improving naturally, great. But if they're not, then treating with an antidepressant is indicated. And we have mirtazapine, venlafaxine, and in the literature, tricyclic antidepressants actually demonstrate benefits in these patients. So I think for those who have been around for a while, they might be comfortable with tricyclics, and particularly in the elderly population. They're not bad drugs; they just need careful monitoring, but they demonstrate clear efficacy. Interestingly, what this recommendation doesn't comment is that there were 2 studies, one in fact with sertraline and acamprosate used together, and patients had better outcomes both for their alcohol and for their mood disorder. So in reality, we need to think of combination therapies. These are not bad drugs, but if we're thoughtful about it, have a proper indication, have done our screening, had those conversations, we could still utilize these medications, but maybe they need to be done in combination with anti-craving treatments. So it is a potentially a complicated story, but I always go down to get a good history. Is this truly a major depressive disorder, a serious psychiatric condition? Is there a clear reason to prescribe? Doing screening tools like the PHQ-9, the QIDS, geriatric depression scale really help clarify this and are fairly quick to use. And then if they have a comorbid alcohol use disorder, are they engaged in addictions treatment? If they are, then you could probably go ahead with an SSRI in combination with anti-craving treatments, but maybe consider an SNRI or a tricyclic. So that's what I would suggest as a way to look at this. I looked at some literature, and it has waffled back and forth over the last 20 years. But I think this information regarding SSRIs by themselves in these patients is important to acknowledge as a potential true harm.
Amazing. Thank you for that. And that's great to know actually a little bit about the combination of sertraline and acamprosate. So it's come back into the limelight by the looks of it, but it's far from a new issue. All right. We're pretty much done. We talked about a bit of background around what's going on, our general approach to alcohol use disorder. We've talked about some specific interventions here. We've wrapped up the case. Instead of doing a formal summary, because you guys can't have access to these slides, I was a bit cheeky and I literally just cut and pasted 2 pages here. Again, these are directly from the Canadian guidelines on managing alcohol use disorder in the elderly. There are 22 recommendations. There's quite a lot in there, ranging anywhere from labeling of standard drinks to thiamine to a managed alcohol program, using CWA to taper IMAP. All the things are here. So if you want your one-stop shop summary for everything that we have talked about, these are the 2 pages to go back and forward to. We skipped over some questions. I do want to say the old Scotsman and Irishman in me says Sláinte means to your health in Gaelic. Next up, we will be talking about opioid use disorder, but now we actually get a little bit more time for those questions. So we're a smidge over time. Does anybody else have any questions?
There's actually one already. Someone had asked just as we finished the last one, so apologies we didn't get to it, but are they providing their own alcohol in IMAP, assuming that they as a patient? In certain health authority facilities, no, it is a prescribed medication, just like any other medication. I'll actually add those little kind of sections of the order sets in. It's either vodka or 5% beer. Those are the options. The for refinement, quote unquote, sort of level is that there are facilities that allow patients to drink their own alcohol. Sometimes it's long-term care, sometimes that's in the community. And with those patients, we kind of do a bit of, it's not really a true IMAP program, but we do a modified where we know that they're allowed to have 1 glass of wine with dinner, for example. And that's kind of an agreed upon preset thing. So that's not exact and not specifically IMAP, because IMAP is a very intentional way of prescribing. But if someone, I do have like a lot of my seniors, actually the majority of them, probably wine is a lot bigger than either vodka or beer. And so sometimes we get a little bit creative in terms of how we're doing that, but using the principles of IMAP. And any other questions?
Can you hear me? Hello?
Yes, we can hear you.
Oh, great. I wasn't able to get onto the Zoom. My name is Carmen Colbridge. I haven't been able to see any of the slides. Just hoping that is there some way that I can get because I do have a couple of incidences in some of the senior homes that I work in. I'm just trying to figure out how I can get these slides to do some education and further education for my team members.
Yeah, first off, thank you so much for chiming in and listening to us, even though you couldn't see the slides. You are a brave person, and thank you very much. Yeah, if you probably, I would say, talk to either Sanita from the LTCI, or who's our other LTCI person on here? I'm sorry, I'm blanking for names. I think it's Jessica Swinburne. So yeah, it is. Yeah, if you can connect with one of them, people can absolutely have these slides, the recording of this presentation. That's a-okay. Yeah.
Sorry, what was her name? Oh, it's
So
in Victoria Island Long-Term Care.
yes, yeah, Vancouver Island Long-Term Care. So there's Jessica Swinburnson and Sanita, I think, is the other person here. Yeah. So the LTCI folks.
Great, thank you so
So
much.
they just put it in the webinar chat. Just email them at victoriasouthisland.ltci@victoriadivision.ca. There you go. Yeah. Email them, they'll give you the slides.
I've also just put a link to the full guideline in the chat as well. Sorry, I didn't name it anything exciting, but
There is a question, is there any legislation around alcohol use in long-term care? Alicia, take it away.
I love how he just throws me the hard questions. So yeah, substances are, it depends where you are and what health authority you're under and whether it's a private or a public facility. So there's actually like quite a few nuances to this question. But the big things around the alcohol use in long-term care are the safety aspects. So there's things that's legislated, like the fire marshal, for example, is legislated. There are things that are legislated like local bylaws. And then there are things that are legislated is like nursing safety. So there's like quite a few components that play into this, but in terms of like alcohol use, there's no specific, like you are allowed X amount of drinks per day. But when it starts to impact other acts or other acts of legislation, whether that's like provincial or federal, that's when it becomes relevant. I don't know if that answered your question, but if you have a specific piece of legislation you're interested about or a specific question, I'm happy to answer that.
Can you
Yes.
hear me?
Yes, we can.
Yeah, so this is, I'm Sarah Polovich. I'm a physician out in Abbotsford. The reason I ask this is because I've had I've never seen any policy around this, but I have had a few fellow medical directors make comments like, oh, we don't allow alcohol in our care community. So I just wondered if that was allowed. Because certainly in the places that I work, we try to work with residents, and I honestly haven't seen anybody like the case that you just described. I was smiling when I was reading that, wondering how we would manage that, but we've got a great team that really tries to meet residents where they're at. But that's why I asked is can somebody declare their nursing home, you cannot have alcohol? That's what I was asking.
Yeah, great. So probably me going down the road of the fire marshals was not relevant, but there you go. Yeah, no, that's a really good question. If it's a private facility, then yes, they are allowed to do that. Just like you can have like alcohol-free retreats or alcohol-free accommodation. That being said, if it's a publicly funded bed, I actually don't think this has been tested. If someone knows better than me, you can certainly pop in the chat. But if it's a publicly funded, like public facility, I think that's actually a little bit more nuanced. I actually wonder if that's been tested, but I think that would actually potentially be a human rights issue. But I think it would have to go to court to prove that one way or the other. But yeah, if it's private facility, yes, they can do that.
One thing, it's Dr. Blashko here. This was an issue with the hospitals, and now it's very clear that it's a harm reduction approach to use. And then the scaling of the risk with patients is how much we control individuals. But at our facility, which is a public facility with Island Health, we do IMAP all the time. there is a happy hour for that's a social drinking hour. So there's no rules that we're breaking. This has been tested with Island Health. We're allowed to do this. This has been discussed multiple times. I don't think there's a provincial guideline, but I would anticipate, looking at the reality of substance use disorders, that I don't think you can actually ban a person from having a drink in a facility. Private places may choose to have people leave, but I actually agree that this is likely going to be a human rights issue. And actually, for people with substantial substance use disorder, harm reduction is probably a healthier thing for the high risk and patient than abstinence. And again, that's sort of a global statement for all substances, not specifically alcohol. So I think we just have to be really mindful of that and not quote policy if it doesn't exist. And just ask the questions of our local leaders. What is the policy here? Is there one? Because I've learned that there are a lot of quotations of policy which are really not. They're more just people's rules, and they're not based on any actual legislative reality. So it's an excellent question.
Yeah, I completely agree with Dr. Blashko. Basically, if it's a public facility, it's pretty clear cut that there shouldn't actually be a lot of nuance. But if it's a private facility, I mean, they can regulate how long or what type of blinds you have or drapes you have in your living room in some private facilities. So it can be a bit good. They can go too far in all directions. But yeah, if you wanted to direct any of those people to me, I'm happy to have a conversation with them. If you think that patients are being underserved or potentially exposed to harm, I'm happy to kind of have that discussion. I also see that Judith had her hand raised as well.
Sorry, just unmuting myself. I was just looking to see if I could put my camera on, but it doesn't look like I can. Thanks, you guys. This is really helpful, and I need to learn a lot more. I'm not sure if I can maybe reach out to any of you later on. I actually haven't dealt with this a whole lot, but I do have one patient at one of my nursing homes right now in Vancouver who, when I first became his doctor, he'd been living at the nursing home for a while. And he'd sort of relatively recently been diagnosed with a head and neck cancer, and he was focused on that. And he was, it was a tonsillar cancer, squamous cell, and he was getting radiation therapy for that. And I think maybe he was feeling crappy and he wasn't going out and he wasn't drinking. So I didn't realize that he actually, well, I don't think I quite realized he was alcoholic. And so, but then as he got better from that, he started drinking more and more and more. And he goes out, he's in his late 60s. He goes out, gets beer, and drinks some of it out and some of it in his room, and drinks quite heavily, but we can't really tell exactly how much because he's getting his own, but probably at least 6 a day, which to me sounds very heavy, although you were throwing around some much higher numbers before. I tried talking with him a number of times. We've had long conversations, and we have a really nice rapport. And initially I like some of these screening questions and screening questionnaires, I would say, don't work super well for him because he also has some cognitive impairment, which seems to be getting worse with the drinking. And so there'll be contradictory answers different times I ask him. I definitely thought there was a depression component to it. So I started him on sertraline. So I'm really glad that I'm here today to find out that I should not have done that. And he doesn't want to, he's after multiple conversations, he really is not interested in cutting down. That's why I thought I'd try the roundabout technique of treating. He didn't want to take anything that would cut down cravings. He hates the idea of medication in general. So that's why I thought I would try the roundabout technique of trying antidepressant. He's not harming anyone else. He's harming himself in the sense that he just looks like he's going to end up dying an alcohol-related death. He's falling more often. He's hypotensive, but he's not at that imminent harm, and he's not belligerent. He's not harming anyone else. So we've all sort of felt at the nursing home that he's allowed to do this, but I've been a bit stumped, I guess, about what else I can do. Obviously I should be prescribing thiamine, which I'd thought about, but I hadn't actually done it yet because he really was refusing to take any medication. And I made my SSRI the priority but I should start that. Any other thoughts? And the capacity is borderline, right? The capacity is not black and white, and he's definitely at this point pre-contemplative.
Chris and Alicia, who wants to take a stab at this? It's an interesting and challenging case.
I agree. I'll start taking a stab. That is challenging, and yeah, a heart goes out to you, Judith. These are some of the more challenging ones. I don't think you did the wrong thing, by the way, with starting the search lane. You know, maybe you could tweak that to something else that's not an SSRI base, and you know, Chris Blashko can weigh in on that. But you know, I actually think your mind was in the right spot there of trying to, you know, address that, you know, the other elephant in the room of his mood there. I would absolutely start something like thiamine. Great, that'll help for Wernicke's protection. But yeah, in the end, what you're left with is a person with, you know, likely an alcohol use disorder who is drinking. They're drinking at risk. The capacity is borderline, but it sounds like they have capacity, and you know, they don't want to cut down. So this is one of those things, longitudinal relationship, continuously having a chat, not to the point where you're badgering them, but you know, you are there as a support. You offer some different things as time goes on. What else? I mean, I guess part of the question is, does your site support IMAP or managed alcohol program? Is that something that you would feel comfortable with prescribing however many, like 6 drinks a day?
I've never heard of it here in Vancouver. Do we have it in nursing homes here? Does anyone know? Sorry, I mean, I can ask our long-term care initiative.
That's a fantastic question. I mean, you guys have been doing this longer than we have in terms of inpatient stuff. Like St. Paul's has had IMAP for ages and ages. But I'm not sure in long-term care if you guys do. Are you in a public or a private facility?
I'm in several, but the particular one he's in is actually become, I think it's kind of like VCH owned and operated. It used to be not for profit, but it got kind of taken over by VCH. So that makes me wonder if we would have access to it. Of any nursing home, it should be accessible through that one, perhaps. So that might be something to look into. Although he would have to still be motivated to do that. And I guess the goal of it would be, how would I sell that to him? What would be the benefit to him?
Yeah, actually, I'm just quickly addressing that first question. In the BC CSU, the very first document I linked, there's actually a list of all the facilities that are doing IMAP. I don't know if that's super up to date, but you can look in there and see if it's on that directory.
So
yeah, usually, oh, go ahead.
No, I was just trying to remember, which document did you say that's in?
It's the one that's titled BC CSU MAP. It's the Canadian operational guidelines.
Okay, thanks.
And there's a directory in there, I think closer to the end, that has all the places in BC that were doing it at the time it was published. So that would be a place to start. But yeah, I'd certainly be interested to know if anybody in Vancouver is doing this with their patients.
And then talking to your question that you mentioned at the end, you know, whether or not he would want this and whether or not he would be engaged. I mean, on one hand, you know, it's free booze. Not to put too fine a point on it, right? Not too many people that I've offered it to have turned it down. So you know, you can use that as a bit of a lure to bring him in, and then you would have some standardized dosing. You know, understand what he's getting. Again, with so part of the I hate to say rules, but the agreement usually around managed alcohol program is that people don't drink outside of the program. That's usually part of the agreement. So that might be difficult with this gentleman. And that's what I tried to highlight in the case is it can be difficult. And sometimes that means you need to up titrate your managed alcohol program. Sometimes that might mean that that patient's inappropriate for that program, and it can be difficult. But what I would say is, you know, see if your facility is on that list. If not, talk to the directors of it, talk to the, you know, managers and CEOs. As Chris Blashko pointed out, this is a validated, prescribed medication. It is based on the best up-to-date Canadian guidelines for substance use disorders in general, and also specifically in elderly. So yeah, I would really advocate, if your facility doesn't offer this, this is a safe and effective tool to be able to provide people with a steady known dose of alcohol And then once you have more time and you built that rapport and he's basically seen you as that awesome doc who's giving him free booze, yay, then you can, use that great rapport that you have over time to either work with anti-craving medications if he wants it, or, try and do a taper, or at the very least, it's okay if somebody says, I want to drink, I've drank my entire life, I want to drink, and this is what I want to do. And, I had a chat with a clinical nurse leader at Summit the other day who was having a bit of emotional distress about this. She's like, oh, this guy's drinking himself to death. If that is within his values and that is what he wants, he's consumed alcohol throughout his life, we're all going to die. And if that's how he dies, that's okay. That is his choice to make, as long as he has capacity to make that decision.
Yeah. And Angela's got a good question. Sorry, I know I'm not the moderator. I just
No, it's all right.
about the prevalence of supports at just 12-step programs, CBT and long-term care. That's a really good point, because that's another thing that I feel we don't really have access to.
Yeah, I think those are very
in the
good
chat.
points. If I could pipe in just for a sec, I just want to extend that conversation briefly of what Chris was saying is we don't really speak to people having palliative addiction issues, but it's true. And sometimes we can articulate that to patients that we will support them regardless of their destination in life, if they're going to die earlier from an alcohol use disorder. And sometimes that acceptance helps patients start initiating change. I've certainly experienced that with some very long stay patients in the hospital on medical units and even in palliative care settings, that when we accept and them fully, completely that they will die from this, it gives them pause. Well, maybe I don't really want to die from this. I just survived cancer. Or maybe he has the existential belief that this is his way to just enjoy himself. So, you can take the conversation to that next level, considering your rapport, and then just say, hey, if you want to just manage this better, we can do these other steps, which I've learned about. And, so I think there is the idea that some of these folks are truly palliative, and we can support them in a very compassionate, accepting way.
Thank you guys so much.
Well, thank you. Yeah, I just want to say thank you to everyone who's chimed in there. Couple of last little thoughts. Prevalence of supports, 12-step program, CBT, long-term care. That's challenging. If your patient is able to get to a local meeting for like a 12-step thing, letting people go out and do that, that's great. I don't know of any supports for 12 steps or anything like that specifically in long-term care. One of the reasons why I brought up CBT is there's lots of CBT online stuff, CBT apps. Again, they're not validated tools themselves. They use a validated concept of CBT, sorry, not CBD. Although anyway, but they, it is a way of people accessing CBT in a care setting. And then same thing with 12-step programs. I mean, I'm sure in this modern day and age, especially having gone through COVID, there's got to be ways to zoom in or something like that to 12-step programs. There's got to be, so I would say, encourage your people to, and it's harder with older folks sometimes, but encourage them to reach out online and use some of those accessible resources.
Just a quick on that one, there are actually older people specific 12-step groups of both Smart Recovery, which is kind of non-secular, and the AA groups or even like NA groups. So if you have people, generally they don't always relate to the 19-20-year-olds in the group. So there are older specific groups which people might like. And another resource is if you have peer support available, like umbrella workers or outreach, usually they have a really good grasp of what's available in the community. And in some places are able to help people get to in-person meetings, not always. And it's very much based on capacity, but sometimes that's helpful as well.
Also, just my last
There's one
comment.
last question, or actually two last questions.
Oh, I was just going to make one quick comment, then we'll get to the questions. Is it only takes 2 people to have a meeting. And so there might be somebody else in the facility that's willing, in terms of a previous experience with AA, and as a facility, you can create space for people to sit down. Hey, there's going to be a meeting. If 2 people show up, you've started a program. So I just wanted to put that in there.
Yeah, I love that. That's a really good point. Yeah, sorry for cutting off. I have my sound turned off apparently. Yeah, there's a quick question about when they have one resident who's allowed to consume alcohol and one co-resident is not allowed. It triggers their cravings. Specific suggestions. The person who is not allowed, I would do a little bit more motivational interviewing around that. Like, are they feeling like they are still having cravings and their goal is to not be drinking? And do they want support in that, whether that's medical or psychosocial, medication, psychosocial help? And then also, is there a feasible way to allow the first patient or resident to have their own autonomy and to consume alcohol, where the second resident is maybe not in the safe space where it's triggering those cravings? Like, is there a feasible way that can be done and explored? But I would actually use this as a really good opportunity to actually do a little bit more around the second resident, because I think there's an opportunity there as well. And then the last question I have is about Judith's case, who loses capacity. Do you taper them off? That's a really good question. I don't know if Chris has an opinion on that, but it's hard because in a lot of other medical cases, we do follow, what someone's wishes would be. For example, resuscitation. What have they previously expressed as their wishes if they can't communicate that? But this is much more complicated because the substance directly is affecting their ability to make those decisions too. So Chris, I don't know if you have a thought on that.
Yeah, I think it's complicated, but that's a discussion with the TSDM. So if the patient loses capacity, they now have a alcohol-related dementia and it's interfering with their functioning in the environment. The only solution is taper, and doing it safely, either through a controlled fashion with IMAP or a CWA is tough with these patients, but I think usually cutting down the amount of alcohol they have access to is probably the best. We've done that at the summit where we've had patients lose capacity, we control their finances, and we get them on managed alcohol and reduce the amount progressively. So I think, yeah, if it's alcohol-related complications and they lose capacity, getting them off alcohol is kind of your only solution, and then that becomes the decision of their TSDM. So try and make it simple to think of it that way.
And you can get a bit of a seesaw sort of motion that we see not infrequently, where people, they don't have capacity, they're, tapered or go have like a CWA done. Then they stop drinking for 3 months, they clear up because now they're not consuming alcohol, and now they have capacity again, and they choose to drink again. And so sometimes there is a cycle until it basically becomes more and more frequent. And I have quite a few patients actually that are somewhere along that continuum at any point in time, just because it does have such a profound effect on people's cognition.
Yeah, thank you both for those. Yeah, what Dr. Pawluk was just talking about, there's at least a couple of people currently in hospital in Victoria with that kind of scenario. So it certainly happens. I would like to acknowledge we are 8 minutes over. We are all very busy folks. And so I do want to let our guests go here. Thank you all so much. Really appreciate it. Great questions, great interactions with us. We're going to continue to try and tweak the technical side of things so it's a little bit more smooth. Alicia threw her email in there. I'll throw mine as well. There we go. That's me. Yeah, we're happy for folks to reach out to us. These are Gmail accounts, so please no specific patient information, but happy to provide advice with a caveat that I'm not exactly an expert on this, but hey. Anyway, thank you so much. Appreciate it. You can get, again, the recording and the slides through our wonderful LTCI folks there. Email has been posted, victoriasouthisland.ltci@victoriadivisions.ca. And we will be back in a month and a half or two or so with opioid use disorder. And then I think Dr. Blashko is going to do a stimulant use disorder because there's a little bit more psychiatric component to that. And we'll keep on going. Also, if you guys have any feedback in the feedback form that'll be emailed out to you in terms of other substances that you would like us to talk about, please weigh in, let us know. The obvious ones are alcohol, opioids, and stimulants, but we can go further if there is a need. So let us know. Thank you so much and have a great day, everyone. Bye-bye.
Thanks, everyone. Thank you very much, presenters. That was wonderful.
Cheers.
Thank
Thank you.
you so. Thank you.